Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to Patient Prep Room, a podcast that explores important and often misunderstood aspects of living with autoimmune arthritis and related conditions in Australia. In this new season of Patient Prep Room, we focus on axial spondyloarthritis, axSpA, an often misunderstood autoimmune condition affecting the spine and joints. Through conversations with expert rheumatologists, a physiotherapist, and axSpA patients, we explore the challenges of diagnosis, the role of inflammation in comorbidities, and practical strategies for daily management. Whether you're newly diagnosed or navigating axSpA for years, this season offers insights and support to help you take charge of your health. I'm your host, Naomi Creek, National Coordinator at GHLF Australia. And in this episode, we're talking with Dr. Michael Yoon, a rheumatologist who works at Campbelltown Hospital in New South Wales, and two patients, Cherie Cleland from South Australia and Shayne Van Der Heide from Victoria, who both live with axial spondyloarthritis. Welcome to you all. Would you like to give a short introduction of yourselves? Dr. Yoon.
Thanks, Naomi. Hello, everyone. My name is Michael, and I'm one of the rheumatologists working at Campbelltown Hospital, as well as South by Southwest Specialist and Shire Specialist in Miranda and also in Gladswood. Thank you for inviting me to the podcast.
And Cherie?
Yes, hello. My name is Cherie Cleland, a 70-year-old woman living in rural South Australia. I was originally diagnosed in 1987 with spondyloarthritis, and luckily it's mostly been a mild disease apart from the addition of some extra autoimmune diseases along the way.
And Shayne?
Yes, I'm Shayne Van Der Heide, 57-year-old who lives in Melbourne, Victoria. I've had ankylosing spondylitis diagnosed for the last 27 years. I've also had a lot of other medical conditions that are also related or not related to ankylosing spondylitis.
Thank you, everyone. Dr. Yoon, can you explain what axial spondyloarthritis, or axSpA, is? It's actually an umbrella term, isn't it, for a few conditions?
Yes, so axial spondyloarthropathy is, I guess it falls under the branch of spondyloarthritis, really. And under that, you have different diseases identity, including axial spondyloarthritis. And another example is psoriatic arthritis, reactive arthritis, and there's many more. So axial spondyloarthropathy is a chronic inflammatory arthropathy, mainly affecting the sacroiliac joint, as well as the vertebrae of the spine. However, we do know axial spondyloarthropathy can affect not just the spine and the sacroiliac joints, but other places such as your peripheral joints, your tendons, and then other organs as well.
Okay, so it does affect other joints, and is that still called axial spondyloarthritis if it's affecting other joints, or does it have a different name?
Yeah, so when we define a spondyloarthropathy, which axial spondyloarthritis is one subtype of it, we will classify them as, is it mainly affecting the axial skeleton, which is the spine and the sacroiliac joint? And then we will also, if there's other joint involvement, for example, if it's a peripheral arthritis, we will call that peripheral spondyloarthropathy. But that will be still under the branch of the spondyloarthropathy. But the term axial spondyloarthritis really kind of stems the sacroiliac joint and the vertebrae spines. But we know that often a lot of the patients that we see, it doesn't just affect the spine and the sacroiliac joints, but it affects their peripheral arthritis within the MSK, and then it can cause emphasitis, like Achilles tendonitis, an example. And then that's within the MSK, and you have other internal organ involvement, such as people we see with uveitis who often get like a inflammation of the eyes if they have an underlying diagnosis of axial spondyloarthritis.
I see. And how is axSpA actually diagnosed? I understand there's also a term called non-radiographic axSpA. So how do you go about diagnosing these?
Yeah, that's a very good question. The diagnosis is actually quite hard with axial spondyloarthritis, and that's because we don't have what we call a biomarkers, unlike rheumatoid arthritis. We know for patients with rheumatoid arthritis, there's a specific blood test that you could do, such as rheumatoid factor and anti-CCP, but yet We don't have that for axial spondyloarthritis. We know some of the genes that's involved with it, such as HLA-B27, that increases your risk, but we don't until now have a specific serum biomarker for axial spondyloarthritis, which is why it becomes quite difficult and challenging to diagnose someone with axial spondyloarthritis. Back in the days where we used to have only x-rays available, it was kind of difficult because you needed to have enough radiographic changes based on the x-ray to identify someone with axial spondyloarthritis. But nowadays we have a MRI that is available, and that became a very useful tool for us because we can actually see acute inflammation on this MRI imaging. The definition has changed now. So when we call axial spondyloarthritis, we're talking about those with radiographic changes based on the x-rays. Whereas the non-radiographic axial spondyloarthritis are those group of patients who has a normal x-ray on the sacroiliac joints. But if you do an MRI and they have an inflammatory back pain symptoms, you can able to see some changes and inflammation on the MRI. And those are the group that we will identify as non-radiographic axial spondyloarthritis.
Wow, that's so interesting, especially how imaging has changed the way you can detect a condition. You mentioned non-radiographic and radiographic types of axSpA. What do we know about how common each one is?
That's a tricky question because we are identifying more because we are recognizing the disease much better nowadays. The proportion in terms of, I guess, the prevalence, if you talk about especially the different genders, with radiographic axial spondyloarthritis, the male to female ratio is usually 2:1, whereas with the non-radiographic axial spondyloarthritis, the ratio between male to female is usually 1:1. So we are catching more of the populations that's now having, I guess, non-radiographic axial spondyloarthritis because of the MRI. And so we are seeing an increase in diagnosis of that.
Thanks, Dr. Yoon. It really highlights, I guess, how nuanced the diagnosis can be. Cherie, I'd love to hear your story. What was your diagnosis like, and what were the symptoms that first made you seek help?
Yes, really, I feel it started with my first pregnancy at age 22, but I was nursing and it was following a back injury in 1986 that I was referred for work cover and saw specialists, and therefore it was diagnosed when I was 32 that it was ankylosing spondylitis or spondyloarthritis. Living in a rural setting away from specialists, the local GPs didn't pick up some previous issues, like I had a really severe knee issue requiring crutches after a while, and that turned out to be a monoarthritis, I was told later. So it was at least 10 years before I was diagnosed. And really, I only needed NAS aids at that time. It was not hugely affecting my life, but enough.
So how did you go about seeing a specialist when you were living in a rural area?
We travelled 200 kilometres to Adelaide, our closest city, and we do that all the time in a day trip. Our daughter does live in Adelaide, so we do have somewhere to stay if I have appointments 2 days apart, etc. When I did have uveitis in 1993, it was 3 trips to Adelaide in a week to see the ophthalmologist to ensure it was healing.
That's a lot to deal with. How did that affect your condition itself and your levels of fatigue and things like that?
Yes, after the first diagnosis in 1987 by Professor Les Cleland, I did have to cease nursing, and eventually I went into the admin side of a medical practice. But so it did end my nursing career. The uveitis, I lost a half a stone in the old terms in a week. It was really debilitating because we had young, inexperienced GPs at that time, and it was quite severe by the time I was referred, and that was pretty nasty, but I don't think there were any lasting effects of that. I have had Achilles tendonitis as well, and eventually that did rupture in about 2012 or 13. It just ate through it gradually despite shockwave therapy treatment.
Wow, lots to deal with there, Cherie. Shane, would you like to talk about your diagnosis?
Yes. So it was probably 10 years before I was fully diagnosed properly as well. I was in my early 20s with the lower back issues. It was a long diagnosis due to the fact I was in a small country town and my GP didn't know what ankylosing spondylitis was, and he referred me to a specialist rheumatologist in Melbourne. From there I started to find out what was actually wrong with me as opposed to being lower back pain.
And how did you feel when you got a diagnosis, or how did it affect your work and other life?
Yes, I continued to work full-time. I was a maintenance fitter and turned into a maintenance planner at that stage. And how did I feel about it? I didn't know anything about ankylosing spondylitis. I had no idea what it was. I knew no one else who had the disease. So I did a bit of research and found out a few more things about it. But it wasn't until I moved to Melbourne in 2011 that I actually found out a lot about ankylosing spondylitis.
And now you're the Vice President of the Ankylosing Spondylitis Association of Victoria.
Yes, and they have been a godsend for me. It was the first person I met that had ankylosing spondylitis was Annie, who is the president of that association, and I started to learn a lot more about it from that period on. And the peer support groups, I cannot say enough about what I got out of that. And hence I'm the Vice President now, and I've been a member for them with the last 14 years.
Well, that's fantastic. Dr. Yoon, we've heard from Cherie and Shane about their lengthy diagnosis. What are the barriers to this early diagnosis, and what are the consequences of leaving it undetected and untreated for so long?
Yeah, look, I think some of the barriers within the diagnosis is, like I said before, and it's quite challenging in terms of that there's no specific biomarkers of the specific disease identity. And further research is being done at the moment, but we have nothing promising at this stage in time. And it's quite difficult because a lot of the patients, we rely on the history of the inflammatory back pain. And some of the symptoms that we talk about, and I'm sure Shane and Cherie will experience this, is an early morning stiffness of the spine and the back when they wake up in the morning that lasts for more than half an hour. Some of the symptoms that gets better with taking NSAIDs like Nurofen, ibuprofen, or sometimes for these kind of patients, when they do stretch and do some movement, the back pain gets better. And then they also wake up in the middle of the night because of this back pain. Those are the classical symptoms that we look at when we talk about inflammatory back pain. But the hard part is not every patient present exactly like a textbook like that, which is why it's so difficult to diagnose. And we do a blood test, and that does help us to an extent. But whether you have that gene or does not have that gene does not make you the diagnosis of axial spondyloarthritis. We then look at other blood markers such as the inflammatory markers, CRP and ESR is what we call, but only 40% of those patients who have axial spondyloarthritis has a raised inflammatory markers. 60% of them, or less or more, have normal inflammatory markers, which is why it's hard for the primary care physicians to be suspecting the disease unless it's quite a clear symptom that patient present with. And then they do a basic workup of the x-ray, and that could be normal because some people have non-radiographic axSpA. And by the time it takes around a year or two, which is the average time we diagnose someone with axial spondyloarthritis, some people will have already developed erosions, or they would have developed some fusion of their vertebrae or the sacroiliac joints, and it becomes difficult. And some of these patients, because they had pain for so long, they start to develop like a chronic pain syndrome, and that becomes quite a difficult also itself to manage as well in the long term. And it's even difficult of getting an access to rheumatologists, especially in the cases that Cherie and Shane has talked about. The challenges that we have as a rheumatologist is quite difficult to get access in those peripheral areas, and that leads to a delay in diagnosis. And really, those are the challenges that we often see. So some patients will present after a year or two, and by then you'll see already some radiographic changes and already see the erosion and damage that's already been done. So I think a good clinical suspicion is very important because there is no one specific diagnostic test for axial spondyloarthritis.
So I guess you're really piecing together different clinical signs and symptoms and imaging results to make a diagnosis. It must take a lot of time and consideration to do that. So How do you feel, or what do you tell patients when you can't actually give them a name for what they have?
That's very challenging, and we see that every day now and then, and all this clinical conundrum because we suspect they have a disease, but we don't. So for these kind of population groups, we will monitor them very closely, and we'll try to follow them up like every 3 to 6 monthly or so to see if they have any development of that disease. Of course, when we see these patients, we ask them to do the normal basic stretches 3 to 4 times in a week, and then also aerobic exercises, and then take NSAIDs when they need to. Usually, we will monitor them with an MRI initially, and then we can do a continuation scan like a year after to see whether there's any changes to the imaging. Because if there is a structural damage and change, then we would know that this may be an axial spondyloarthritis. But it is, of course, quite frustrating for the patients because it's not like you have a clear diagnosis. So it's like, being in a gray zone. So I could see that is quite frustrating for the patients. But at the same time, it's important to make the diagnosis and not overcommit to it just because once you've had the diagnosis and we treat this patient, we use a lot of medications. Our drugs are immunosuppressants, and then that drug itself has its complications. So we do monitor them quite closely, and it is easy to fall under the pit and say you have the diagnosis. But I think it is important that for those patients, we just monitor them closely and then see how it pans out.
Interesting. So you would use more of a conservative approach, take some baseline scans, MRIs, and advice of some exercise and things like that, and see if there's some changes over time and then reevaluate. Is that correct?
Exactly right. That's how I would see it for those patients who has unclear diagnosis. And if their symptoms are a mix between inflammatory back pain and osteoarthritis, and then they have all biomarkers are normal, MRIs initially are normal, I'll monitor them very closely without jumping into a treatment straight away for these patients.
So is an MRI a standard thing for a patient that has suspected axSpA? If a patient has been told they might have it, but they're not getting the MRI, is that something they should really push for to have that scan done?
Yeah, good question. So if the history of the back pain sounds more inflammatory and X-rays are normal, but we can't justify the raised inflammatory markers, and for example, the HLA-B27 might be positive, yes, absolutely, I think we should go do an MRI to look for any acute inflammation. But some people tell you straight away that it all sounds like a degenerative, non-inflammatory back pain arthritis, and the biomarkers are quite reassuring. I don't think we will be jumping straight to MRI and look for other causes. Because even with the MRI, there are flaws with the MRI. Because it's a quite sensitive scan, it could pick up those edema on the sacroiliac joint, but that does not necessarily mean they have axial spondyloarthritis. Because even degenerative arthritis can have some sort of inflammation at the sacroiliac joint, but then we will have to look at the location of where it is. And then obviously the history will tell if they do a more mechanical kind of a job. And those are the things that we'll be looking into and counter for, because all inflammation or bone marrow edema we see in the MRI does not mean that the patient has axial spondyloarthritis. So again, you've got to be quite cautious with the diagnosis, even with the MRI itself, which is why it is quite tricky.
Before we get talking about the treatment side of things, Cherie and Shane, how did you feel about your diagnosis? Was it clear cut, or, I know it took 10 years in some cases, but was it a maybe for a while and then you got told it was this, axSpA?
Not really. It was Professor Cleland, and I did test negative to all of the markers, rheumatoid factor, HLA, B27, etc. My CRP is never elevated, even now, whereas my ESR is always between, say, 30 and 60. It has been up to 80 or more. So I was satisfied with the diagnosis in 1987 because he took into account that my left sacroiliac joint had a restriction of movement following the pregnancy, and I did have Achilles tendonitis and the upper, like cervical and lumbar pain. The X-ray showed loss of lordosis and some issues. So I felt satisfied reading the booklet he gave me about ankylosing spondylitis that it did make sense.
It was a little bit more clear cut. When I was diagnosed, they gave me a fairly firm decision that I'd hit all the markers to say I had ankylosing spondylitis. The only problem I had was my rheumatologist wasn't a very good communicator, and I didn't get a lot of information out of him in the sense of what it was all about, and I was only seeing him for probably 5 minutes every time I drove down to Melbourne to visit him, and I didn't get enough information out of him to actually understand my disease and what life for me was going to be moving forward.
So you really would have liked some literature or something like that to take home and read.
Yeah, something to give me a little bit more information on what it was all about. As I said, I've found another rheumatologist now who's a very good communicator, and I consider him to be one of the best in Melbourne when it comes to rheumatology, and he goes beyond and gives me so much more information now than what I used to get.
That's wonderful to hear. Dr. Yoon, do you provide printed literature to patients, or I guess these days it's more maybe website links and things like that to help them understand their condition?
Yeah, I do. You know, the young people, they tend to don't like the printed handout these days. They just bring their iPad, their phone, and they say, "Can you just show me?" Because I'm probably better off reading that. So for the young generations, I just show them where to go to get the informations. Whereas a bit of the later generations, they prefer to read the handouts, and then I'll just provide them, and then they're pretty happy with those. I usually always give information on the diagnosis, especially through the ARA website, the patient information. They're very useful. And then if I prescribe any medication, I will always provide the information sheet, because this always helps with the patient just to understand what's going on. And then they also should know what kind of side effect it implies with the medication itself. So I think that is vital.
Dr. Yoon, what are the current treatment options available to help control axSpA?
So usually when we first make the diagnosis of axial spondyloarthritis, we often tell the patient it is important that we do aerobic and also the stretch exercises. We recommend at least 20 minutes of aerobic exercises 3 times a week, and that could also be a group exercise as well as at least 5 times a week of stretches. In conjunction to that, they'll also take NSAIDs if there's no contraindication, and that could be like a naproxone, Celebrex, or meloxicam. There are options of NSAIDs. We usually try that and see how the patients go. If they're in a mild spectrum of the disease, some people will that will be enough. And some people will have enough, I guess, the medication and enough their stretches and the exercises that they'll come back in 3 to 6 months' time and say, I feel much better. We will monitor those patients quite closely, and if they do well, they do fantastically. And there are some good prognosis patients that we often see. But if it is not, and then they still get a lots of pain, and then what we do a BASDAI score to see what the scale of the severity is. If it is quite bad, then we will consider using a immunosuppression, what we call a biologic therapy. And then there's other subtypes of biologic therapy that we'll run through with the patients and making sure that their blood tests and everything is okay before we commence them.
The exercise and the anti-inflammatories, that's the criteria to get onto the biologics, is that correct?
Yeah, exactly right. It's just because that is the first initial treatment that we have. And if they fail that, despite them doing for more than 3 months with the NSAID stretches and aerobic exercises, then we can consider for biologic therapy if they meet other criteria too.
And how many different types of biologic options are there out there for patients?
There are quite a lot now these days. We have our TNF alpha inhibitors, we have the IL-17s, we have the JAK inhibitors. So we have a lot of options within that.
That's good. It's a lot better than what it was 10 years ago, huh?
Absolutely. There was no biologic therapy, exactly right. So we often say to the patient, look, you can probably live a normal life, even with the diagnosis of axial spondyloarthritis, because we have such a good treatments out there nowadays.
And so they really are halting the progress of the disease when they get on some of these biologics?
Exactly right. There's no cure to the axial spondyloarthritis, but we're managing the symptoms and then I guess the delay in the radiographic changes.
Fantastic. Cherie, what sort of treatments have you tried?
I did originally have the NSAIDs since I was 32, basically. I've been on those. Eventually, the bloods showed inflammation with the ESR and my platelet count, I think, was becoming elevated. So 2002, I started methotrexate tablets. I went through Arava, sulfasalazine and prednisolone before I started the first biologics, Enbrel, Humira, Orencia, Symphony. I tried all of those injecting at home between 2006 and 2011. My rheumatologist at the time didn't leave me on methotrexate, so possibly I'm not sure if that's why I lost effectiveness quickly to all of those. So in 2014, My pyodermic gangrenosums started in 2011. I eventually found that infliximab infusions every 8 weeks, they stop the pyodermas and ease the arthritis and also the inflammatory bowel disease. It fixes all three. So I've been on that since 2014.
Right. The gangrenosum, that's a type of ulcer, isn't it?
Yes, it's an ulcer. It can occur anywhere inside or outside of the body. Mine originally started on the left shin. I had in the throat. I no longer have a uvula, and also in the vulva region. I've had biopsies of all three areas, and luckily the first biopsy was a large specimen. It grew really quickly and would look like a aggressive cancer, but they cut it out, which gave a diagnosis more easily. It's so rare that even the pathologists have trouble diagnosing it.
Wow, that must have been a hard thing to deal with, all of those, the back pain and these extra conditions.
Yeah, it was very painful.
Shane, would you like to share a little about your treatment journey?
Yes, I started off on anti-inflammatories. Naproxen was the one of choice that I ended up getting a few ulcers in the stomach from taking that, and a couple of them had bursted in periods of time, so had to have some rectification for those. I have been on Humira for probably 8-9 years now, and I started off with injections and now I use a pen, but the Humira helps a great deal. I also find a hot shower first thing in the morning helps prevent some of that stiffness that Dr. Yoon was talking about. I ride push bikes. I used to do a lot of swimming until a neck injury stopped me from swimming again. But yeah, I do hydrotherapy as well, just to try and stretch out in the warmer water.
Mm-hmm. So keeping moving is really key for you.
Yes, movement is good, and the warmth in the back. So I have a lot of heat packs that I use during winter that strap around my lower back. Also, some of the medication that I was taking was giving me kidney function problems. So that's another issue to add to my long list of medical conditions.
We'll talk maybe a bit more about that in the next episode. But Dr. Yoon, what are the challenges for rheumatologists in choosing the best treatment for their patients? Obviously, we've just heard from Shane that the NSAIDs have caused some kidney problems. I guess there's always the risk there of these causing some problems, and that's the balance of that benefit versus risk, isn't there?
Exactly right. Obviously, the conservative measures of aerobic and stretches is all doable, but NSAIDs itself brings a lot of complication, especially with those who has chronic kidney disease or those who previously had a gastric bleeding, because NSAIDs can cause that, as well as if they have a high cardiovascular risk. Those are all the risk and contraindication that you have to consider when you're prescribing those NSAIDs therapy for these patients. And of course, the biologic itself, we can go through another topic of the biologics, that would be another hour or two topic of itself. But, with those medications, they are immunosuppression. They're quite strong medications. So we screen for them, especially making sure there's no active infection. And before we start the medication, we'll talk to the patients about their history. And, it's choosing what the right medication is for that right patient. But that itself is quite challenging because we have, up until now, no specific thing that this medication will work for this patient. It's a generic medication and hoping that medication will help the patient, because based on our study and trials, they did help a lot of the patient with axial spondyloarthritis.
I see. So how do you decide when to, change a patient to another medicine? Because as a patient myself with rheumatoid arthritis, you sort of develop this new normal, which is actually not the best normal it could be, and we sort of live with that pain that we probably didn't do before. So I imagine this is the same across a lot of autoimmune conditions, in that there's possibly something better up there. So how do you decide on, no, there's actually something better for you?
Yeah, very good question again. I think the patient will often tell me exactly right, like say, look, this medication is no longer working for me, or they will say to me that it used to work 100% now, but before the next injection, I feel like I can't do normal daily activities, or week before the injection. And you start to think, are they building tolerance to the medication? And once you get to know the patient quite well, they will prompt you, and that means something. For us, especially for axial spondyloarthritis, we do a score called BASDAI score. Because we know that CRP-ESR is not a reliable marker, BASDAI score is there to show a bit of a questionnaire to the patient. How bad is your pain when you wake up in the morning? How long does the early morning stiffness last till? It's all these questionnaires that we gather and then come up with the scoring system to determine whether it's mild, moderate, or severe of the disease activity. And that's the best kind of thing that we use. And even when we're prescribing biologic therapy, they'll need to meet certain criteria for that. So I guess if one, for example, Humira, which is a TNF-alpha inhibitor, let's say that medication was good for a couple of years, but it stopped to have an effect, then we will switch over to another different types of TNF-alpha inhibitor because, that's a secondary failure. So the medication has worked. But if they have a primary failure, for example, they use Humira and it did not work within the first 3 to 6 months, then my inclination is maybe change to a different subtype of a treatment, such as NIL-17, secukinumab, if there is no other contraindications.
Right. So, and it's really making that decision with the patient together, isn't it? A joint decision.
Exactly right. And for some patients, like for example, they prefer infusion, like infliximab infusion, rather than doing the needling, obviously every 2 weeks for Humira. And that's because that suits their lifestyle. All of the patients, especially coming from the regional area, might prefer the injection because they can do it at home. They don't need to come to the tertiary hospital every time they get an infliximab infusion. I think you got to consider the patients, or you got to tailor the treatment to individual patients. I think that's the most important thing.
Yeah, that makes a lot of sense, actually. So talking about that, the discussions you have with patients, how can patients get the most out of their appointment with you? Because I know there's always a limited time with appointments.
A lot of the patients come to the clinic with a list of things they want to discuss. That's kind of handy for me, I suppose, because the first 5 minutes, I let the patient talk. And then the patient will pretty much give me 90% of the information that I need anyway through that list. And then that is a good way to go about it so that they will write 5 questions that they want to ask me. They prioritize what's the most important and what they want to discuss. And as long as I do at least 4 or 5 out of those questions, they are usually happy. And then I'll be asking 2 or 3 questions just to make sure that we do check all the ticks and boxes. And I suppose once you have been diagnosed with axial spondyloarthritis, you would know your rheumatologist, and the rheumatologist would know the patient quite well. And then you kind of get the sense if they are not happy or if they're in pain, they will give you a little bit of nudge. And you can tell when a patient walks in from the waiting room to your room, you would know straight away, okay, they're in pain or they're not in pain. You can tell by how they walk.
Yeah, I bet you can. So, Cherie, how do you feel about your appointments with your rheumatologist? Do you feel satisfied with your treatment?
Possibly not enough now. I have tried for so long to say that I feel the infliximab isn't as effective after this time, but because of my other complications, the infection risk, they feel it's not right to increase the dose yet or to change to something else because they just really don't want to risk the pyodermas returning. This is the most effective against it, so I just have to use pain relief now, and even that is difficult to get. I can't take the NSAIDs anymore because of my kidney failure, and they've taken away access to codeine, so Panadol isn't enough, and so there is that stress of finding someone who's prepared to give ongoing pain relief. At the moment, I have someone who is giving me Panadine Fort in larger quantities, so it is something I would like to change infliximab and certainly have one that I can administer myself at home, but at the moment there are reasons why.
Thanks, Cherie. And Shane, how do you feel about it?
Yeah, I always have fairly open and frank conversations with my rheumatologist that I've got now. We both understand each other and we understand that my body a little bit better than what my previous one did. I had to get off naproxen because of the kidney function problem that occurred from that. I started taking the medical marijuana tablets. They've become fairly expensive, but that was the only way I could stop the discomfort. I'm a person that sleeps about 4 to 5 hours a night due to discomfort in my lower back. And I've had to get off I've actually been able to get off the medical marijuana after having some recent surgery, actually in my brain for Parkinson's, but for some reason that's triggered the relief in the pain that I don't need to take that tablets anymore. But I'm on Humira, I've been for 9 or 8 years, and with the exercise I do, it seems to be okay. As anyone who has AS lives with pain as part of their life, and you just get used to it after a while.
Thanks, Shane. Cherie, looking back, what do you wish you knew earlier, either about your diagnosis or range of treatment options that were available?
Yes, so with a nursing background, I find Dr. Google very helpful for understanding some aspects of X-rays or MRIs, and you really do need to ask if you want a knee replacement now. They're reluctant to do joint replacements. My sister's just been through a terrible time where they try all sorts of other things, but it's just not the same. So she has now had a knee replacement. So I think knowledge is important with helping yourself advocate.
And what about you, Shane?
I found out that what I didn't know was a lot more than what I did know in the end. So I would have liked a lot more information at the start. My involvement with the AS support group in Victoria has given me a wealth of knowledge, which I now pass on to other people as a mentor. But what I knew at the start, I knew nothing, and it was and not knowing anyone else that had it was a little bit difficult trying to navigate what was true and what wasn't true in that sense.
Yeah, I think knowledge is wealth, like what Cherie said. I think that's very helpful to give as much information to the patient when you first meet the patient and give the diagnosis, because when you give the diagnosis to the patient, it's obviously a lot of information and it takes them time to absorb those information. I think it's important if you do have given information handout that patient can have a read about it. And during the next consultation, it would be ideal if the patient, which a lot of the patients do with me, they come up and say, hey, I read about this information. Can you please explain this medication side effect, this and that? And I think that's a way of making a good relationship with your patient, able to explain and justify what other questions they have, because it's a long thing to absorb. And like I said, because our diseases are not a cure, but they are chronic lifelong diseases, I think it's very vast and important to explain to the patients about all the information with the disease and the medications. So I think joining a support group, if they have the community support group, is always a good thing because you can share this information with the others, like what Shane said. And I think we just need to have more of those really and involvements.
And I must say, since being diagnosed with smouldering myeloma, I have taken part in team meetings, which are a great way to meet other people and gain knowledge. There's always a liaison nurse involved with those. I can stay home. I don't have to actually go to Adelaide where the meetings are held, and I find that very helpful. I subscribe to Creaky Joint Australia and other arthritis emails I receive.
Dr. Yoon, before we finish up, is there anything else you'd like to share? Maybe a takeaway for patients listening today?
Yeah, look, I guess if I was in that shoes, I will probably, and obviously this is no disclaimer to anything, I will probably see another doctor for another opinion and to say, hey, look, I went to see the initial one, but this is the symptom that I have. Do you think it's appropriate for me to see a rheumatologist? And probably go from that onwards, I think. I don't think it's right just to stick with one thing and just say, I'll be like that, just because, two brains better than one, I suppose.
Shane, it sounds like having a good connection with your specialist made a big difference for you. Did you want to add any final thoughts on the value of second opinions?
I'd strongly recommend a second opinion because, I had that with my first rheumatologist. The lack of conversation that we had and what I learned in 5 minutes with the next one was phenomenal. So if you're not happy, go somewhere else.
Thanks so much, Cherie, Shane and Dr. Yoon for sharing your honest and thoughtful experiences. We've learned that early diagnosis, having access to the right treatment and finding the right support network, whether through health professionals or peers, can really change the course of life with axial spondyloarthritis. We've had a powerful conversation and I know our listeners will really take a lot away from it, so thank you. Thanks for listening to this episode of Patient Prep Room. Click follow wherever you listen to podcasts and join the Creaky Joints Australia community to receive additional resources to help you live your best life despite arthritis. Join for free at creakyjoints.org.au. Creaky Joints Australia recommends that you always consult with your medical provider to ensure you remain at the centre of your healthcare. This podcast was made possible with support from UCB Australia. If you've liked what you've heard, be sure to rate our podcasts, write a positive review, and spread the word by sharing with your friends and family. It'll help more people like you find us.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.